Thanks, Ron. So, my case, case one. So, the history. There's a very common scenario. You guys have all encountered this before. A 20-year-old elite rugby player, no previous history of dislocation, makes a tackle, get his arms reefed up into a position of external rotation, abduction, has severe pain, loss of function, deformity. The diagnosis in the field is motor V anterior dislocation, and it's reduced by the team physiotherapist. And everyone goes away happy. Okay, so what is the most appropriate initial investigation? Who would choose an ultrasound? Okay, so Jerome's message has gotten through. How about an X-ray? Who would choose an X-ray? Okay. An MRI scan? Initial investigation, guys?
No.
Okay. CT scan, anyone do a CT scan? No. Bone scan? No, bit off piece. Okay, so the most appropriate initial investigation is an X-ray. Why? You want to confirm the diagnosis. You probably did have a dislocation. You guys get good at assessing dislocated shoulders, but occasionally it's not. I had one patient, exactly the scenario, who got taken to hospital, who got on the field, tried reduced by paramedics. They tried 7 or 8 times before they decided it was finally in. I saw him, his arm was in a sling, and it had a grade 3 AC joint dissociation. So it went through all this trauma for nothing. The other thing you want to exclude is a fracture. Well, you want to make sure it's located, if it was in fact a dislocation, and to make sure that you need 2 films at 90 degrees to each other. You need a true AP and a scapulolateral as a minimum. That's not quite a true AP, but it's good enough with the scapulolateral. Okay. You also want to make sure they haven't got any fractures, because that's going to affect the immediate post-operative post-injury management. Okay. So examination, the patient's neurovascularly intact. They have poor elevation, some weakness in external rotation, and a positive Napoleon's test. So regarding initial treatment, who would vote for sling immobilisation for 6 weeks? No one? Good. Abduction, brace and neutral rotation for 6 weeks? No, it's urgent surgery. There's always one. Okay. Sling for comfort, then physiotherapy. Okay. True? No? Okay, or body binder for 6 weeks. No, okay. All right. So, regarding sling immobilisation, there's no evidence that prolonged immobilisation makes any difference for recurrence, okay? There's one slight exception. The abduction brace for 6 weeks was something that's been trialled, and it does seem to suggest it may decrease the recurrence rate. What it basically does is putting your arm in an abducted, slightly extended rotated position approximates the Bankart lesion to the anterior glenoid, therefore help putting it heal. The problem is that no one can tolerate it. It's a real pain. You know, I wouldn't have it myself. Urgent surgery, you know, like possibly in a professional athlete to get them back into action fast, but the vast majority of people know. Sling for comfort for physiotherapy is the most appropriate thing. You get them back to normal functioning pretty quickly, or functional shoulder very quickly. Body binder for 6 weeks. I happened to dislocate my shoulder when I was a kid, well, about 17 or 18. Got treated by an old orthopaedic surgeon who placed me in a body binder for 6 weeks. I wouldn't recommend that to anybody. It was terrible, and it didn't make any difference. Okay, so on a 6-week examination, patient's got a full range of motion, a very mild painful arc, rotator cuff strength has come back to normal, but he has a positive apprehension and relocation test. So, who votes for a CT scan for the next investigation? No one? An ultrasound? No. MRI scan without dye? Okay. An MRI arthrogram? Okay, fantastic. And a PET scan? No one. Okay, great. Okay, so it's important to do an MRI arthrogram. If you don't have dye on the shoulder, it's almost impossible to adequately assess the labrum. So it's just saying that this is his MRI scan. What you see here is it's called that's a bony Bankart lesion. So he's avulsed his anterior inferior labrum with a small piece of bone, and at the back of his shoulder, that's a Hill-Sachs lesion. Okay, and you can, if you follow the normal contour of his humeral head, you can see you lose it here, and that combination is not ideal. So going on to treatment, who votes for continuing physiotherapy? You guys got a vested interest in this one? Okay, all right, no one much. Arthroscopic stabilisation in someone who wants to continue playing rugby? No one? Arthroscopic stabilisation in a remplissage. In case you don't know what a remplissage procedure is, this is it here. It's an arthroscopic stabilisation, plus it's augmented with putting the infraspinatus into the Hill-Sachs lesion to stop it engaging. No takers? Okay, an open stabilisation? A few. An Lattiger procedure. Okay, so everyone's a bit non-committal. Okay. But I guess that's not your...
You've already wasted 6 weeks, Ivan.
What's that?
You've already wasted 6 weeks.
Okay. All right, sorry.
Should have had it done up front. So
this is a discussion point that we would talk about. Generally speaking, if this guy, he's a young guy, his chance of recurrence without going back to contact sport, somewhere between 70–90%. With those bony lesions, it's higher than that. It's more like 90–95%. Arthroscopic stabilisations do very poorly for contact athletes, particularly in the presence of bone loss. If he was not going to back to contact sports, you could make an argument for an arthroscopic stabilisation and a remplissage procedure. An open stabilisation, again, you could make an argument for that, but my preferred option in this case would be a Lattiger procedure. You, especially with that Hill-Sachs lesion, I think it's a very high chance of recurrence. And if you want to go back to contact sports, to me that would be the best option. However, some of the panel members might have other ideas. Duran?
Yeah, look, the issue with for those that don't know what a Lattiger procedure is, you cut the coracoid off and then screw it onto the front of the glenoid. And for me, the indication for doing a bone transfer procedure is absence of bone on the anterior glenoid. There's been a couple of studies that came out of Japan that were presented at the International Knee and Shoulder Arthroscopy Society meeting earlier this year, and they showed that if you screw a bone graft onto a normal shape and size glenoid, the bone graft will reabsorb over about a 2-year period. So all the theoretical advantages of doing a Lattiger procedure in someone that doesn't have bone loss are lost. So for me, in this situation without significant glenoid bone loss, I would do an open stabilisation, not a bone transfer procedure. There's a fine line that you have to then get a 3D CT scan and look at what's called an on-track, off-track lesion, and then make the decision, then do you need to replace some bone because of the glenoid, the humeral side of things, but for the majority of the population in this situation, for me, would be an open stabilisation.
Yeah, I approach this a little bit differently. An elite athlete who plays a contact sport at the age of 20 who dislocates their shoulder once, the chance of redislocation is 100%. And every time they redislocate their shoulder, they do more and can do very significant articular cartilage damage. So if I would have seen that patient first up, I would have got an X-ray and an MR arthrogram the next day, and I would have suggested surgery straight away for the same reason as rotator cuff surgery. There is bleeding, there's an inflammatory response, the healing of the labrum is going to be enhanced by the cytokines and growth factors released by the inflammatory response. If it was an in-season or pre-season dislocation, what I would do is I would advise them, if they didn't have significant bone loss, to have an arthroscopic procedure, and I would send them back to football at 10 weeks. We did a series many years ago using players from the Dragons, the Steelers, that were that was a long time ago, now I think about it, and the bulldogs. And we did, well, over 12 or 13 of these patients, and providing they didn't have significant bone loss, they didn't have a recurrence. If it was an out-of-season dislocation and they had 6 months to recover, then I would do an open stabilisation, which is the gold standard for contact sportsmen. The results of open stabilisations in contact sportsmen are much better than arthroscopic ones. If they had insignificant bone loss, I would just do a soft tissue procedure. But if they did have significant bone loss for all the reasons that Doron explained, but they would have to have significant bone loss mainly in the glenoid but also in the humeral head, I would do a Latarjet procedure. But if you do a Latarjet in the absence of significant bone loss, the bone graft resorbs and you have a screw sticking out that rubs on the humeral head and causes arthritis. And a number of recent papers at the Shoulder and Elbow Conference in South America revealed that in the absence of bony loss, the resorption rate was in 50% of patients, which is not insignificant. A Latarjet is not a benign operation. It's got a much higher complication rate than any other shoulder instability surgery and should be used with caution, in my opinion.
Great. Okay. So, moving on to case 2. This is a 75-year-old woman, falls at home, pain and dysfunction in her shoulder. She goes to casualty. Diagnosis is made of a dislocated shoulder and it's reduced. She's placed in a sling, reassured and referred to her local medical officer or GP. Unfortunately, she fails to improve, and on examination she has poor active elevation, her passive range of motion is intact but painful, external rotation strength is diminished, and she's neurovascularly intact. So regarding her diagnosis, does anyone vote for a frozen shoulder? No. Osteoarthritis. Locked dislocation? A stroke? No. Or a massive rotator cuff tear? Yeah, so it's clear, I mean, the first 3 have been excluded by the X-ray. She hasn't got a stroke and she's got a massive rotator cuff tear. So investigations, ultrasound, we'll learn that lesson. CT scan? No. MRI arthrogram? Good. MRI of her brain? No. An axillary view, okay. Okay, so looking at the MRI arthrogram, this is why it's great to get an MRI arthrogram, because you can read the scans yourself. I'm not sure if you noticed it, but MRI scan reporting in Sydney is highly variable to quite a bizarre degree. So with dye in the shoulder, you can actually look at the scans yourself and can actually see the tears. So this is, so looking at, there we go. So on the axial view, this is looking straight down, that's the humeral head, that's the glenoid. This is, does anyone know what that is? Any guesses? Can you remember something, anything about shoulder anatomy? No? Okay, I'll give you, it's part of the rotator cuff. Okay, it's your subscapularis. So that's the front. This is that's the bicep groove. So you know that's at the front. Rotator cuff muscle at the front of the shoulder, subscapularis. Okay, so you can see that's normally attached to the major attachment to lesser tuberosity there. It's pulled straight off, and you can see the dye going through that gap, elucidating that really nicely. What do you think that is? Any ideas? Anyone? Bicep, yeah, it's your long head biceps tendon. So dislocated biceps. So, what's this thing at the back here? Any ideas? Yeah, infraspinatus, yeah. So don't be scared of MRI scans, they just show you normal anatomy. okay? You just need to have a look and not be intimidated by them. All right. So going to the where's this thing? So going to the coronal views. So that's obviously the humerus. That's obvious. Oops, what have I done? That's obviously the glenoid. And coming up here, what's that? What? Pardon? No. Okay. It's the supraspinatus. Okay, so you can see it really clearly. Compared to like a ultrasound scans, which is like an old black and white TV off the channel, you know, can really elucidate this, and you get a lot more information. You can tell, you know, the quality of tendon, quality of muscle, what's torn, where it is, any other associated damage. Okay, so this is a sagittal view when we're cutting through the scapula, and you sort of think, well, why is this important? Any ideas why it might be important, given some of the stuff we were talking about? No? Okay. Well, at least we got the ultrasound message across. So basically, what you're looking here is the quality of the rotator cuff muscles in particular. And what we're really looking for, we're talking about what's really important in rotator cuff, treatment of rotator cuff, like whether they're going to be repairable or not repairable, what's their prognosis is. It's not so much the size of the tear, it's about fatty atrophy, okay? And you can assess the fatty atrophy from the MRI scan. So this is a supraspinatus sitting in the supraspinatus fossa. And there's actually a classification system, the Gattellio classification, and basically it's four classes. One is nothing. So that's got no fatty atrophy at all. It fills in that fossa completely, looks great quality muscle. So this is an acute tear, okay? Grade 2 is when you start getting streaks through it. Grade 1's the streaks. Grade 2 is when you've got fat there, but there's more muscle than fat. Grade 3 is when the muscle and fat are equal, and grade 4 is when there's more fat than muscle. And when you get into those grade 4 and grade 3 changes, your chance of having a successful rotator cuff repair is minimal, okay? So you've got to be that's really important for assessing management and prognosis. So, treatment for this patient. Physiotherapy. Right. Corticosteroid injection and physiotherapy. Okay. An open rotator cuff repair for a big tear. Arthroscopic rotator cuff repair. Okay. A bit more enthusiastic. All right. A reverse total shoulder replacement. Anyone? Okay. All right. So this patient's got pseudoparalysis shoulder. They've got a massive rotator cuff tear. They've lost almost entirely their elevation of the shoulder. In my opinion, they require surgery. They're highly unlikely to get a shoulder that they're going to be happy with non-operative management. You might get the odd person that does, but usually they don't get great function, and it almost certainly deteriorates over time. But it wouldn't be. If people are reluctant to consider an operation, you can try it, and also, you know, this sort of thing also depends on the patient's demands and their expectations. But as far as getting the most predictable thing for optimal long-term function of the shoulder would be to have it repaired, in my opinion. If they're reluctant, it's not unreasonable to try physiotherapy. You could supplement it with a cortisone injection, although that will decrease. You'd have to then wait before you do rotator cuff repair, with the consequence of waiting. Now, if you wait too long with these people, they develop significant fatty atrophy, because it can kick in quite quickly. It can start within 3 to 4 weeks, but that's highly variable, okay? Open rotator cuff repair, it would be reasonable if that's what the surgeon does. Arthroscopic rotator cuff repair is pretty much the gold standard these days. And this patient at this stage doesn't require reverse total shoulder replacement. So we'll talk to the rest of the panel. Doron, what are your thoughts?
In fact, I've been monitoring the webinar questions, and there's been a few questions about the natural history of rotator cuff tears. You know, if someone's got a 1 centimetre tear versus a large retractor tear, at what point is the decision making that the person needs an operation? And I guess, you know, from my perspective, the rotator cuff tear is a bit like a crack in the windshield of your car. It's going to start off small, but over time it's going to get bigger. We don't really know exactly what that time frame is, but we do know that if the tear gets big enough, the humeral head rides up and then rubs on the acromion, and then you're going to get a rotator cuff tear arthropathy. So for me, younger patients, active patients, I'm almost always going to offer them surgery because I'm worried about the long-term consequences of leaving that tear unrepaired. And certainly in this acute injury, ideally I'd want to be operating within 2 months if I could, because I've had situations beyond 3 months where we couldn't actually get the repair back to where we wanted it to be. So for me, I agree 100%. This person needs an urgent operation.
Yeah, I'd agree. Jerome?
Yeah. If you look at that case and you look at the theory of force couples, in this case, the vertical force couple, supraspinatus is torn, and of the horizontal force couples, infraspinatus is intact, but subscapularis is torn. So the force couples are such that it's very unlikely that non-operative measures are going to benefit this patient. However, she's 75 years old, and I would say to her, look, you know, there's an option of an operation, and in my hands it'd be to start off with an arthroscopic cuff repair. But in the event that the patient was reluctant to undergo surgery, and a lot of 75-year-olds are reluctant to undergo surgery that has a 6 to 9 month rehabilitation, I would say to them, look, let's try some cortisone injections and some physical therapy. I don't think that will work, but the cortisone injections have the potential to make the tear bigger by softening the remaining rotator cuff. And this may be a case for PRP rather than cortisone injections, because PRP have healing cells. They haven't been shown to reduce the or to increase the extension of the tear and soften the cuff. Can you comment on that, Paul?
Yeah, that's interesting. I know over the years you've sent me plenty of patients in this category that didn't want operations, and a lot of them do very well. So cortisone to settle down their pain, and then an assisted rehabilitation program, and they actually, a lot of them do get function back in the shoulder. So as for PRP, I guess it's what you're trying to achieve. Certainly, you're not trying to achieve a repair in the tendon. That's impossible. All you're doing is maybe putting in a potent biological anti-inflammatory, much as we would in an osteoarthritis patient, to make the shoulder more comfortable and allow the same rehabilitation process to proceed. I couldn't say that I have had the opportunity to put PRP into a patient like this, though, so I'd be just speculating.
John, yeah, okay.
I think it's important to let patients know how their life's going to look in 5 and 10 years. So if there's longevity in the family and cardiac-wise they're good, it's fairly predictable what's going to happen in 5 or 10 years. The good news, I guess, is that when you look at, say, reverse shoulder replacement surgery, and I'm speaking as a physician now, the recovery is much easier than a rotator cuff repair. The immobilisation is shorter, pain reduction's immediate. So they may make that call of not going for surgery for their cuff, and they're prepared to wait 2, 3, 5 years, and at age 78 or 80 having a reverse then, which may last for 10 years or so, 15 years.
Reverse is actually, the 10-year survival rate for reverse total shoulder replacement was 95%.
So mapping that out just helps the patient organise themselves, I think.
Okay. Right. So just one last case, exactly the same history, but the injury is now 8 months old. Okay, so if you look at the MRI scan now, you can see you've lost almost the entirety of the muscle bulk of supraspinatus and almost entirety of the muscle bulk of infraspinatus. So this is what you really don't want to see, okay? So treatment, physiotherapy. Yeah, I'd go for physio in that case. Corticosteroid and physiotherapy. Yeah. No? It depends on the patient's symptoms. Like open cuff repair, and you want to go for that? No. Arthroscopic rotator cuff repair? No, it's not going to work. Reverse total shoulder replacement. What you can do with these patients, depending on what they've had in the past and what their symptoms are. If their symptoms are pain and loss of function, there's no hurry to rush into anything. You can inject them, get going with physiotherapy. If it improves their pain, if they get a sort of functional shoulder that they're happy with, they're fine. What you often find, those will end up with a dysfunctional or a painful shoulder, and particularly painful shoulder, those people do very well with the reverse total shoulder replacement. And this is often the situation where you find yourself in if someone's opted for non-operative management with a massive rotator cuff tear, and then they come back. Sometimes they do okay to begin with, but almost invariably they tend to deteriorate over time and end up in this situation. Okay. Thank you.